I would focus it on.
Thank you very much, ma'am, for a very wonderful lecture. Now I request our chairman to present Dr. Sangita Reddy with the ASCII memento as a token of our thanks.
For presenting it, I want to say very inspirational.
Not quite receptive to the entire concept of. So, ma'am, I understand a lot of things is being done about this. So, ma'am, according to you, what can be done different or more in order to make this a real building block?
Mr. Nagabhushanam will propose the formal vote of thanks.
Disorders, diabetes, where India has 85 million diabetics, and systemic chronic disorders like diabetes are the beginnings of multiple other disorders. When that non-communicable disease starts going up, then the healthy lifestyle has a higher role to play. And our ability to create a healthy lifestyle in most rural environments is not too difficult, and I'm going to share more about that. But we need the data to study this because the new important mantra is going to be population health. It used to be about bed to patient ratio, it used to be about patient to doctor ratio, population to doctor ratio. But it's actually about population health because there is a preponderance of a certain disorder in a certain area. And you all have heard of, whether it's iodine or chromium or lead or each one of these. When we look at the population and overlay that data, then immediately as administrators, your ability to handle that particular problem changes entirely. Or your ability to correlate unhealthy lifestyle patterns with higher preponderance, whether it is, we're doing a detailed screening in Manipur, and I'm going to tell you about the incidence of chewing tobacco and mouth cancer, which is an obvious one. But all these will come up, and the solutions will become clearly visible when we have unbiased, well-captured data. And moving on, I think the important thing also is the internet divide. Because much as we all love, the important aspect of telemedicine, if you don't have access to the internet, then how do you do telemedicine? When we did our first telemedicine in the year 2000 in our village in Argonda, we put together 4 telephone wires. And Bill Clinton, actually switched on the button, and 2 days before he came, we got scared if that may not work, so we asked ISRO for a satellite. And we put a small satellite because, showcase, chief minister, all that stuff. But we went on with satellite for 4 years, and then steadily our internet connectivity has got better and better. But today, when we're trying to do countries in Africa, when we're trying to do remote villages, even in Indonesia, we do mental health for remote villages in Indonesia, and their internet connectivity is not so good either. So the internet availability and the digital availability is becoming one of the important data points in health equity. And the last one really is AI. Our ability to have AI, use AI, to be interpreted across all levels. And I'm going to share more this thing of what is clinical AI, what is operational AI, and how does it signify. But this is really a mental map that I want to leave you with. That if we look at these important and interesting new areas, typically we used to look at access to medicines, beds and infrastructure. I'm taking all this infrastructure as a given and superimposing a new accelerator to health equity, which are these 5 critical points. I want to share with you another aspect which is accelerating and kind of changing the health profile as we look at it. And these are 4 trends which are driving health equity. So number 1 is really that the disease profile is changing. And why would I say it's a positive trend? The reason I'm saying that one is, of course, it's a trend that there's more non-communicable disease, but NCDs can be controlled by information, by knowledge, by healthy lifestyle, by early prevention. Whereas infectious disease, you go out, you catch something, it's not within your control. And you need science and an ecosystem and government to give you a vaccine and prevention. But NCD is in the hand of the population to manage themselves. And that's why it could be turned into a positive trend towards health equity. The second important one is that the area of care is shifting. We used to think that, the only place is the high-end hospitals. But care is shifting from the hospital to the clinic. We can do so much more in a clinic. And Mr. Richard is sitting here. He's a director in one of our companies where we have 400 clinics, and he knows how much we're pushing health checkups and clinics and prevention. But care is shifting from the hospital to the clinic, from the clinic to the home, and from the home to a 24/7 ubiquitous access to care enabled by your mobile phone and connectivity. So 5G ambulances will give you care in the ambulance. Your phone will connect you to your doctor, who will escalate in a call center, who will have an AI model. Your nurse will take care of you. You need not even go to the hospital for most things, except when you need a major surgery. Many of these things you do. But this is a very important thing, that the point of care is shifting. The is suffering from mental health. And why this is extremely serious is that all of us are in denial. Most hospitals don't have mental health departments. Most communities ostracize going to a psychiatrist, and the burden of mental health is translating into a higher suicide rate for many, many communities and segments of the population. So again, I kind of put light on this one, because unless we handle this appropriately, and it can be handled, we will be solving one segment of the problem while a different segment of the problem continues to grow. And the digital solutions in this space are outstanding. They are chatbots, they are avatars, they are interpretations, there's privacy. There's so much that can happen in terms of innovation in mental health. And that's why I wanted to take a minute on this. And leave you with this one thought, that WHO estimates $1 trillion is the cost of mental health to the world. So it is very significant. Moving on to, I think, my last slide in this series is just a culmination, or maybe one more, is that a combination of universal health access. And by universal health access, I want to take a minute to tell you another story, which is the story of Apollo Health Association. And most of you would not have heard of it. But Apollo Health Association was started 37 years ago, inaugurated by Lectureby, who was then the health minister, with the primary purpose of bringing health insurance to this country. And this was done as a result because while we were doing outstanding high-end surgeries and work, we also realized that health was the second most major cause of indebtedness, and people were selling their land or pawning their wife's jewelry to pay for our hospital bills, and that did not feel very good. But we also knew that the income levels will not grow as fast as we need them to, and health insurance is the only way. So AHA was a non-profit society to build awareness and to create research about insurance. In the year 2000, we did the first insurance model in the country for our village for 700 people for 1 rupee a day. We used that data to create the ApoloHsptl model for the police of Andhra Pradesh. We used that model to build Yashashwini in Karnataka for 300,000 farmers, and then brought that model back to Andhra Pradesh to do ApoloHsptl. We ran the back end of Yashashwini for 9 years and the back end of ApoloHsptl for almost 15 years. So health insurance, and then finally we had the privilege of deposing in front of the parliament. I spoke before the insurance bill was passed to say this is such a great need. And India is one of the few countries in the world where health insurance is in the health category, in the general category, and in the life category. And this has allowed us to create a 51% penetration of the country with health insurance. 220 million people are covered by PMJY. Another approximately 100 million people are covered through the different state schemes who don't go into PMJY. And the rest is another 200 million covered by the private insurance. So approximately 500 million people are covered by health insurance, which is a significant achievement. Because now they worry about healthcare, not so much about the bill. And this is the way it should be. But besides that, in the same breath, I think when Prime Minister Modi spoke about PMJY, he also spoke about primary healthcare clinics and making them health and wellness centers. So there 200,000 clinics and 75, the third piece is the health records. So if you see this slide, I'm talking about universal health through insurance, digital health through the National Digital Health Mission and primary healthcare. These three pillars are the foundational pillars towards health equity and universal health access. But then it gets more exciting. Patients live outside cities. We need access to the doctors who live in high-end care. 50% of the world's children are undernourished, or 51% of India's children are undernourished. And then the ratios move from Africa to the other. The missing middle is definitely critical, but also the extreme poor. While they're getting the carbohydrate, they are still undernourished because of the lack of protein and micronutrients. And the social determinants of health, like clean drinking water, sanitation, and nutrition, are by far the most important. We put up new CT scans and proton machines, etc. But if you asked us, what would you think is more important for the overall health of the country, we will definitely talk about primary health care. And so as I begin this presentation, where is your, okay. And yet if you look at the routine cost of care, when we started, we used to do bypass surgery for about 85,000. Even today, we can do bypass surgery for about 1.2 lakhs. The inflation in bypass surgery is lower than the inflation. Even onions have gone much higher than, the inflation rate is more. This is because of a series of things. Because of knowledge, because of training, because of the cost of machines, and now with India manufacturing in here and consumables getting manufactured here. And finally, the most important is don't look at the actual cost of bypass surgery, whether it's 2 lakhs or 3 lakhs or even cancer treatment. The cost of a bypass surgery is 20,000 rupees, which is the cost of your health insurance to buy it. Because the burden of disease of the very sick, who are only 5% of the population, is borne by the community in a well-insured population. So with the model and the manufacturing and the changing environment, the cost of care can actually come down. So I'm giving you something which was typically counterintuitive, but it is true. And finally, the last one is a ubiquitous AI. These 4 trends are going to help us accelerate. And I'll talk more about AI later. So we'll move to our next slide, which I think is important. And this one is really thinking about healthcare at a community level and the interventions required to create health for all. Local community interventions, whether it's the food you eat, whether it's the way you dispose your garbage, or your sanitation conditions, and therefore you prevent gastrointestinal disease because you've created that. Many of these. And typically people would say that, we spend so little on healthcare, we're only 2% of our GDP. Unless we spend 5% of our GDP for healthcare, how will we achieve healthcare? I used to say these things. And now, India spends $176 per person on healthcare. America spends $11,582 per person on healthcare. India's current life expectancy is 69 years. US's life expectancy is 77.8. It's not a very big difference for 10 times the amount of money spent. But then it gets even more interesting. India's cardiac deaths are 235 per 100,000, whereas US's cardiac deaths are 335 per 100,000. So it's the time for us to start thinking that we are going beyond a direct correlation of money spent and outcomes and begin to focus on population health, innovative interventions and positive outcomes. And that's what the current environment is enabling all of you to think about. And that's why I'm daring you to take this moonshot of health equity for the world. So there are many other channels, whether it's the management of chronic disease, because if I handle diabetes right, I will prevent you from having a bypass surgery. If I manage your diabetes and keep your HbA1c at 5 and 6, we will make sure you don't lose your eyesight or have to amputate your leg. And if I find your cancer at stage 1, you will not only be able to be cured, but you will be cured for a smaller cost and much, much less suffering. So one of the important aspects of fighting in NCDs is early intervention. Towards early intervention, and I have this, next slide please. I have this, a few data points of what's happening in the country, and these are primarily government related. Many of these, I have the honor of being on the Planning Commission, on Niti Aayog's Health Committee and Design Element. But we have finished 800 million screenings in this country. This is non-trivial. 83 million people have had breast cancer screening. 56 million people have had cervical cancer screening. And you have 400,000 ASHA workers. And I realize there's still a gap. Anyone who's sitting here and saying, I went to my village, things are still quite bad. Somebody else may be thinking, I went to Gandhi Hospital, I saw so many people who had stage 4 cancer. It is not exactly where we are right now, but it's the direction in which we're going. The acknowledgement, 5 years ago or 10 years ago, you never had this number or this orientation on prevention and early detection and screening being a methodology to prevent non-communicable disease. And that's why I put this first slide in front of you. The second slide, while I gave a positive note there.
Pleasure, privilege to propose vote of thanks on this occasion. Whenever I attend this annual memorial lecture, there are two persons always come to my mind with emotional attachment. One is Dr. VChandramouli, who gave immense support and strength and guidance at the time of this formation of our essential medical services, which is a no-profit organization. And I salute him from my heart of hearts. Secondly, Dr. A.P. Rangarao is actually my classmate for the last 40 to 50 years, and we were all together spent quite a bit time in establishing this EMS with the help of Dr. Chandramouli Garu. And Rangarao, A.P. Rangarao is the actually founder, and he has taken lots of pains. I know how much pains he has taken, which we couldn't, ordinary doctors, we couldn't take it and spend that much of time. So he used to think always day and night to establish how best we can take the health care to the poorest of the poor. That was the main aim of that. So that is the reason why we started actually in the village telemedicine, and we are still running for the last 20 to 30 years. So Dr. Rangarao is the founder and struggled hard to form this non-profit organization, that is EMS. On his last wish, Dr. Rangarao's wish was, because we established that one, Chandramouli Garu helped this, and we wanted a memorial lecture, and we requested ASCI to establish a memorial lecture on his name. So, and Dr. Chandramouli. And now I thank the senior most Dr. Padmanabhaya Garu, Chairman of the Court of the Governors and Administrative Staff College of India, for personally gracing and presiding over this function. And sir, your presence definitely added a grace and value for this function. And I thank very much on behalf of our staff of EMS. And secondly, I profusely, wholeheartedly thank Dr. SangitaReddyJMD, so Joint Director of ApoloHsptl, for delivering this. Really, we were very much, I haven't come across such a good picture with all the things. Definitely, it is a very interesting and illuminating guest lecture. And I also thank O.P. Singaru and Ashti Garu for this making such arrangements. And once and for all, I thank every invitee or guest and students for attending this function and making it a success. Thank you very much.
This country we're going to be future leaders. But I always say, and we're going to hear Dr. Sangita Reddy very soon. But one point is, I always say, hospital and hospitality. Two very similar words. So we talk, why the hospital, not hospitality? What does that mean? What did I say? What does it mean? Sorry?
Means everything doesn't go, that hospitality is not seen at the hospital, not seen at
Hospitality, the patient needs to feel cheerful, needs to feel happy, needs to feel cared for. Because the patient is suffering. So hospitality, some of the hospitality is bright, hygiene, cleanliness, nursing, being attentive, kind, gentle, caring. That's hospitality. So one of the things in administration is about culture in a hospital. And you'll hear about that, I'm sure. I'll be there